Good afternoon, everyone. I'm Ronnie Baticulon. I'm a pediatric neurosurgeon at the Philippine General Hospital. This is the Southeast Asian Pediatric Neurosurgery group. So for those of you who are new here, we're a group of pediatric neurosurgeons from Southeast Asia. And we usually meet every month to discuss cases. So we also give pediatric neurosurgery lectures. So it's usually a 1-hour meeting, and this started during the pandemic. The nice thing about it is we get to share our experience with each other and we learn from each other. Now, for this month, we're doing something different. We've invited one of our good friends, Dr. Kish Mankad. He's the chief pediatric neuroradiologist at the Great Ormond Street Hospital. And he's gladly obliged to our request for him to give a lecture on updates on the imaging of pediatric brain tumors. This is really an informal lecture. We'll give Dr. Kish 50 minutes to give his talk, and then we'll have time for questions. While he's giving his lecture, maybe just request for you to put your microphones on mute. And then if you've got questions, just please raise your hand so we can entertain them at the end of Dr. Kish's talk. Once again, thank you so much for coming here this afternoon. Dr. Kish, the floor is yours. Let me just stop my share.
Thank you very much, and thank you everyone for attending this as well. I hear that this is a cross-disciplinary group, so we are going to wear several hats, and as a speaker, I can't be a pure radiologist when I present these findings to you. And I think whilst we look at the spectrum of what is emerging as new and redefined tumor entities, it's important to start thinking how, as a neurosurgeon, you would have approached that problem or the tumor, and how, as a radiologist, you would have described it or considered the various differentials. And if there are pathologists in the audience, I'm sure you will agree with me that pathology itself is becoming a little blurred out at the edges at this point in time, and it's questionably the gold standard test in many centers, which are beginning to do more. So the more you do, the more you find, and the less accurate the black and white differentiation becomes. Now, that's controversial, but it is provocative at the same time, because one of the few conditions that we are dealing with in terms of pediatric brain tumors is the whole landscape of gliomas, for instance, which in itself is not just one mutation within the matrix of the tumor, but a lot more that you encounter, and the more you test, the more you find. And it is a constantly mutating landscape that we are trying to image. So it is a shifting goalpost. And that is why I think we are lagging behind, and we will continue to lag behind in terms of radiology catching up with pathology, etc. But the quicker we do that, the better it is for the patients, because our surgeons and our oncologists can target those therapies. And is there one target or more than one target? So let's look at some cases. But beginning of time, I think it's important to realize as to what's going on in this age of precision medicine. And if you look at the story of this 10-year-old boy as a warm-up story, really, who presented with seizures initially. And if you focus your attention on the very simple sequences that we do, and whilst a lot of speakers in the world will tell you we do spectroscopy and we do this and that, I think the bread and butter sequences are still the T1, T2, the flare, the diffusion, which is very important, and the post-contrast sequences in the beginning of time, at least at baseline, to characterize these lesions. And I use the word lesions with caution, as in this particular case, there was ill-defined signal abnormality, patchy changes in the left temporal lobe. And when they presented with seizures, the diagnosis was viral encephalitis. Given that the temporal lobe was involved, people started thinking about HSV, and a lot of CSF and other tests followed. Then the child was covered with broad spectrum antimicrobials in the hope that this is not infection, it could be something else. And then so on and so forth. And maybe some people were considering, should we be giving steroids? Could this be a post-infectious or an autoimmune process following infection? And maybe they were all right, because at the end of the day, I think infections are driving many of these processes still across the world, so to say. And then the radiologist comes along and they start putting their markers and they start looking at ADC values, for instance. All this is possible on our PAC systems wherever you're practicing. But as a one-off baseline scan, these values make no real significance. And you can see that we are not really picking up much in the way of restricted diffusion and so on and so forth. So, whilst we were scratching our heads and this child was being treated as an encephalitic presentation, they continue to deteriorate. And we know the theme of this story is tumors. So, we have to realize that this is how the trajectory of management and investigations go. Child has a biopsy because they're not responding to steroids and high-end immunomodulation therapy, and the biopsy comes back as showing an astrocytoma, which is on histology, followed by immunohistochemistry, which shows a high Ki67 index. That means the proliferative index is quite high. And then these terms start coming into the radiology report and the pathology report. The methylation is unclassifiable. The next generation sequencing solid tumor panel. And a lot of centers now would start doing these tests across the world, because that has become the basis by which you would define the molecular signature or the biological behavior of a lesion, and then use the WHO 2021 classification to be able to identify what the subset is. So what used to be simplistic up until 2016 and kind of restricted to pretty much there, and the pathologist would give a diagnosis of an anaplastic astrocytoma in this particular case, or even a so-called glioblastoma multiforme, and then a high-grade glioma pathway would be followed. That has changed a little bit in terms of trying to determine what subset it is. But these technologies are still coming with this disclaimer on the package that this is under research and should be interpreted with caution and in the context of other investigations. So, whilst we are looking at that, the initial diagnosis is made of anaplastic astrocytoma of the left temporal lobe, and all these various tests, the IDH and the histone status, come back as wild types. Now, there is no target to treat. The patient is therefore commenced on a bit of a non-targeted regime at this point in time. And then 6 months later, there is further progression, and the diagnosis is revised from anaplastic astrocytoma to bilateral glioblastoma multiforme, because by this time, the tumor has spread in a diffuse fashion to both the hemispheres. But if you think about the pediatric tumor landscape, it's very different from what you would define as glioblastoma multiforme in an adult. And you're already thinking well-defined, enhancing, highly aggressive mass on one side of the brain, spreading to the other sides. For sure, you would call that a GBM. But the term GBM itself is questionable in pediatrics now after the new classification system, and we will see why. So, whilst we are still trying to treat this child and they're deteriorating in front of our eyes, the prognosis is going to be quite poor. We get back the results of the next generation sequencing. The methylation has failed, and we'll come back to what methylation actually means. And I think that's still useful for radiologists and surgeons in the audience. We are using these terms a lot more in our discussions. But look at the landscape of this tumor. It's not just one mutation, you have a hell lot going on. And the more you test, the more you find in terms of likely pathogenics or pathogenics or variants of unknown significance. And then the pathways that these genes are basically activating. And if you just focus your attention on entities like the PIK3, the AKT-mTOR pathway here, or the hedgehog signaling, they are very distinct pathways. And if we are talking about targeted therapies in 2022, we would be administering drugs which would actually interrupt one or two of these pathways. Now, think about the philosophy of a tumor. If you block one pathway, what generally tends to happen is the other pathways get hyperaccelerated. So we are not able to control this complex tumor matrix in an effective manner by just targeting one particular pathway. And this is the true picture of how we get our reports from pathology these days, which becomes tricky in terms of, are we going back to basics, non-targeted therapy, or should we be looking at each of these? And then you give a whole cocktail. So management is complex. Now, what happens to AB from 2 years from disease onset, from then anaplastic to GBM diagnosis? This is what the state of the brain is in the meantime, spreading across both sides. Looks like inflammatory signal still, but there is a little bit of mass effect, still not enhancing, still not restricting on diffusion. So enhancement is not a discriminator in pediatric tumors. Diffusion may not be a discriminator even in high-grade diffuse gliomas like this, and the child eventually passes away, and these were the final kind of moments before they die. Just look at this picture. Is inflammation really far away from neoplasm? If you go back to Latin derivatives of rubor, calor, dolor, tumor, those four aspects of redness, inflammation, swelling, it's all happening in all these various conditions. And that is why radiology also tends to go into the non-specific realms quite easily. But I think it's very important to have the low threshold to start calling things if the patients are not responding to the initial line of management. And maybe we could have made a difference, prolonged his life or quality of life, which is more important at this point in time than actually just prolonging the agony. But 2 years, the child continues to deteriorate after everything being thrown. And we can see why, because that was never one tumor or one mutation to start with. And this whole concept of one mutation, one tumor, one gene, one tumor does not work in practice. And that comes with a caution again, because you interrupt one pathway, you're going to activate and hyperactivate the other pathways. And the relapse and rebound that happens with certain entities in the context of our diffuse midline gliomas, for instance, in the pons, is well-known fact. And we're beginning to see that in the low-grade spectrum as well. So really, what could we have done differently? And it's not a direct answer to this question, but we could have kept our antennas up, we could have kept our differentials a little wide, and we could have looked a little more closely into what this lesion was doing in terms of spreading in its mass effect, and then kind of go back to understand what the emergent literature is. This is how the WHO advocates in 2021 in its classification book. So each tumor type now has an essential and a diagnostic criteria. And I'm sure all of us don't have access to this book. I haven't seen the full book, but I've seen excerpts from it. Each entity, for instance, diffuse low-grade glioma, which is a MAP kinase pathway alteration, has got the essential, so it has to have all these criteria. You've got some positives, you've got some negatives in there, and some desirable criteria. And if you look at this picture, just try to absorb it, you will realize that there is a scope to kind of factor in age, location, as well as the genetic makeup of that tumor. But radiology is not as strongly present in those essential and diagnostic criteria. And the role of imaging, therefore, is first of all tumor localization. And the second thing is to try and understand the differences in outcome based on what mutations may be harbored or not. And that is why we are doing a catch-up game, but there is a relevance in that because these are quite distinct even on imaging. And really, we can blame the WHO for letting the dogs out on us and making it more complex. But the whole idea is actually to try and cluster these tumor entities in distinct subgroups and move away from histology. Histology only tells us about the degree of differentiation, but move away from histology into the realms of biology, and that biology is being dictated by these particular mutations. And therefore, entities like diffuse low-grade gliomas, diffuse high-grade gliomas, the focus is on the word diffuse in these two entities, and within them, the various subsets. The ones that I have underlined here are the relatively new and the revised entities per WHO 2021, and you will be encountering lots of these terminologies in the pathology discussions in tumor board. And within those entities, we have the diffuse hemispheric gliomas, the diffuse midline gliomas, and then this diffuse high-grade glioma that we just saw, which are wild type on both histone and IDH mutations, and rarer entities like infantile hemispheric gliomas, which seem to have a different trajectory and outcome compared to the other high-grade gliomas. And we will kind of just restrict ourselves to diffuse because we just saw an example at the moment and come back to the more circumscribed ones later. Important thing to remember is that the term anaplasia has been dropped. So really, pathology reports will not be coming with this term anaplasia in pediatric realms. We wouldn't be seeing glioblastoma multiformes because it has been restricted to use in adult IDH wild-type tumors. And this whole context of grading within the subtype. So you first define the cellular lineage and then try to grade within that as to whether it is a mutant or a wild type. And then if it is a mutant, as to what subtype it might be. And it's only ependymomas which are still based on location in terms of classification, where you have the supratentorial ependymomas, infratentorial ependymomas, and the spinal variants. And in children, that holds quite well as well. We'll see some cases. The other thing that changed drastically is the numbering itself, and you can see how complex Roman numerals can be into Arabic numerals, which make it simplified in terms of numbers, and sometimes a line missing makes a big difference. So it was getting a bit more complicated. That has been shifted back to Arabic numerals. And I must tell you, the Arabic numerals themselves are a misnomer. It was actually not discovered in Arabia as such. Discovered somewhere in Greece, if I'm not mistaken. But anyway, these are called Arabic numerals, and this is how we are used to looking at numbers, which makes it more simplified. In the current age, therefore, the story starts with radiology and a radiological diagnosis. So it's important for the radiologists in the audience to actually give what they think is close to the diagnosis or a close differential. It's not possible or even legal just to say that this is a mass and leave it at that. Location is what has to be accurately designed and defined in your report. Is it ventricular, paraventricular, for instance? Sometimes it can be quite tricky. Where is the epicenter of the mass? And that makes a difference to the surgeons in your audience, because the surgeons then start planning the trajectory for surgery. If you say it's a thalamic tumor, they have to think twice as to how that's going to be approached without damaging the corticospinal tracts, for instance. And if we say it's a brainstem mass, already we know that resection is not going to be total in many of those instances. That leads to a biopsy, and a safe biopsy is what I should have called this. And the safety of biopsy is determined by the confidence of radiology. If, as a radiologist, I say this is undoubtedly, or until proven otherwise, a high-grade tumor, then our surgeons who will go into the brain will try to get most of it out, because the outcomes for any of these tumor types is best when they are totally taken out by the surgeon. And ependymoma is the best example of that. We have a few millimeters of ependymoma left behind. We expect our surgeons to go back in and take that out, because the longest progression-free survival, the outcome is still based on a clean post-op surgical scan. But when you have situations like diffuse tumors, it's important for them to know that, because they are not going to have a pretest probability of complete resection. Or if we think it's a low-grade lesion, then the surgeons will be a little more kind of calm in terms of taking a pinch of that tissue, getting the targeted diagnosis right, because low-grade tumors are indolent, and when you subject them to chemotherapy and other options, they might actually respond quite well. So that aside, the tissue is then taken for deep freeze, and fresh frozen tissue is looked at instantly within the theater itself or instantly after surgery. And what that gives us is a tissue for microscopy, immunohistochemistry, and most of the diagnosis can still be made within those two realms, and has been the traditional practice as well. And then we have methylation analysis, next generation sequencing, and now what is being more commonly done is whole genome sequencing. And you will see a lot of papers on single cell RNA and many other technologies that's coming up, essentially trying to determine the genetic makeup as best as possible. But armed with that information, it goes to the tumor board or the multidisciplinary tumor meeting, and a final integrated diagnosis is given. And the final integrated diagnosis can be done, as I said, at the level of immunohistochemistry. You can see that the way the brain stains can define the lineage of the cell. And traditionally, this gave a lot more information already before the advent of further technologies like methylation. So a little bit of word on methylation, and this I had to teach myself because people were using it quite freely. And I was struggling to understand what it meant. It's an epigenetic phenomenon. And methylation is a normal process that happens in nature. So you have the DNA helix, and I had to draw this to explain to myself. So I used it on my slide. And methylation actually attaches these methylation particles. They attach to these sites. And there are areas of normal DNA which has the unmethylated islands, so to say. These are called CPG islands, going back to the cytosine guanine makeup. And then we have the cancer cells, which could be under or over methylated. In essence, what happens is there is a balance. So you've got methylated, unmethylated parts of the genetic helix. And if their balance is maintained, then the oncogenicity and the tumor suppression is maintained. But if the balance is tilted, then it leads to transformation. And it's an epigenetic phenomenon. It doesn't actually affect the basic genetic structure. It's what's added on top of that. Different tumor types have distinct methylation profiles, and the 2016 classification of the WHO was actually based on pretty much that advent. And people in Germany out there created the Heidelberg DFKZ classifier and were able to start clustering tumors into different groups. And this was AI at its best, deep machine learning, and start putting different groups and clusters. And when you start looking at this cluster now, the so-called histological based diagnoses of tumors started separating out. So you had your glioblastoma multiforme in one place, and then you have the high-grade ATRTs far away. The ATRTs were separated out by the medulloblastomas by a mile, so to say, on this particular map. And then what we are now beginning to cluster as embryonal tumors, for instance, is itself spread out far and wide. Medulloblastomas there, CNS neuroblastomas, there's ATRTs far away. And these clusters are based on, again, their biological behavior, not on their histology. Within the medulloblastomas itself, you can see a far out separation of the different subtypes. Now, in our center, there was a national call out early on. I think a couple of years ago, this paper was published in terms of how good this new technology is. If we are going to do methylation analysis, are we going to make a big difference? And there was an alteration to diagnosis in 35% of the historic cases, but it changed treatment in 4% of those cases, which is still substantive because these are long-term treatment regimes children are subjected to. And that kind of equated to 120 change treatments in the USA per year, for instance. And these numbers are here to take or not to take as significant, but this was based on an observational real-world data cohort. And in 62 cases, the diagnosis still remained unresolved in many cases out there, out of the 484, even after putting methylation analysis in. And then that kind of led on to looking at, shall we be looking at whole genome sequencing, etc. At the same time, certain other centers, this was a more recent paper from 2021, looked at next generation sequencing, both DNA and RNA-based technologies with chromosomal microarray analysis, and they were able to show clinically significant alterations in 66%. So it does add value. The bit that is, however, missing in this is the gap analysis. Now, when the new classification came out, and we are practicing in countries which are in the various first, second, and third world slots, the LMICs, etc., the technology was expensive. But is the cost of that new technology offsetting the cost of wrong or untargeted therapy or wrong therapy for a long duration? That gap has not been plugged, and the health economics evaluation of this technology is still lacking. So if people out in many parts of the world are trying to adopt this new technology, they will struggle to find the economic backing, and therefore funding becomes tricky in many centers. Why should somebody fund so much evaluation of this particular tumor type when the outcome is going to be grim anyways? But as an analogy, we often say that under GA MRI scan might be more expensive than actually getting the methylation signature of the tumor. So it's a balance, but we haven't really been able to do that effectively. But though I started this process, the manuscript started 3 years ago, I haven't got anywhere close to the finishing of this, because how do you then go back in time and pick up cases and look at and blind them in a way to see if they had the technology of genetics thrown at them, how their outcome would have been different. So if you have any ideas and you want to collaborate on this, I'm very happy for you to reach out to me at the end of this talk. And the other side of this picture is the accuracy of this. Is it really going back to this basic evaluation of tumors that we do as surgeons and as radiologists? 6-year-old girl presenting with an acute visual loss, and you're picking up a supracellular mass, CT thrown in there, and the differentials are 2 or 3 types here. And you look at curvilinear calcification on that CT scan, you're going to call this a craniopharyngioma until proven otherwise. Some of you might be thinking, could this be a germinoma? Could this be a high-grade astrocytoma? Maybe. All those are differentials or supracellular tumors, but this has been there for a while. It's expanded the sella turcica. It's got long-standing ventricular dilatation. The diffusion metrics are a bit patchy, and then this curvilinear calcification. So the radiology comes back and they say, we think it's a craniopharyngioma. True story. This was a 2018 case, and the technology was still evolving, but the pathologists come back and say, oh, well, on our methylation, we think this is a low-grade glioma with a BRAF V600E mutation. Now there are targeted drugs to this particular mutation, so the patient is commenced on targeted therapy. That was their baseline scan. They're given BRAF V600E inhibitors for 18 months. Now that's an expensive drug. It was a trial, but the tumor seems to have grown in those 18 months. It's a low-grade mass, so it's going to grow slowly. And the questions at this point were, could this be a pseudoprogression? Because we can see pseudoprogression in low-grade tumors as well, and it typically happen in 1 or 1.5 years' time. Or is this a tumor that is progressing? It is true progression, or have we just got it wrong? So a histology was repeated at this point in time after much discussion, and the child was definitely deteriorating in the background. And the final diagnosis of this case came back as a revised diagnosis from a pathology perspective of craniopharyngioma. So sometimes these methylations can fail. It's not, and that is why they still come with a disclaimer that it's a research tool and we are trying to make it better. But like any test, having a troponin I of 0.9 equates to having an acute myocardial infarction. But having a troponin I of 0.8 with chest pain and ECG changes does not mean it wasn't an acute myocardial infarction. So where do you define the cutoff of significance? I think that balance is still not clear in some of these cases. So do take those pathology reports with a pinch of salt. And if your pretest probability for a particular diagnosis is strong, stick with it. We talked about diffuse gliomas. There you have the entities of the circumscribed astrocytic gliomas, some new kids on the block here, like chordoid glioma, the high-grade glioma with pyloid features, very exotic diagnoses if you think about it, and we wouldn't think about it instantly when we look at a scan. We would still end up calling it a glioma, maybe an astrocytoma, maybe low-grade or high-grade. So we are still kind of wallowing in those very low levels of functioning, but histology and pathology have gone beyond. And these do have different outcomes in terms of their clinical trajectories. And within the gliomas, extension of that would be the glioneuronal and neuronal tumors. And that's a longer list at this point in time with entities like DGO and C, and not trying to make you remember all these various mnemonics. I'll show you an example of how these tumor entities come into existence. You've got the diffuse leptomeningeal glioneuronal tumors, and this entity that I've never seen yet of cerebellar liponeurocytoma, for instance. But again, a step back. Grade is a differentiation of cellular type. What is grade 4 in terms of tumor types? Now, if you have a molecular glioblastoma as in adults, it's a grade 4. In children, if you have a diffuse midline glioma, it needs a confirmation of a histone 3 K27M alteration status, then you make it a DMG, and the DMG is instantly grade 4. The moment you pick up this mutation, it becomes a grade 4. And then you have the other entities, diffuse hemispheric gliomas. And the only change in these two entities is a one amino acid shift that completely changes how the tumor looks. So let's look at this diffuse midline glioma entity a little more deeper. First of all, we know that they commonly were encountered in the pons, but can happen in the thalamus and may happen in the spinal cord as well as primary or secondary tumors. But to make a diagnosis of a diffuse midline glioma, you need the mutation. So radiologists cannot make this diagnosis in the baseline scan. They can suggest it unless this is confirmed as an H3K27M. Now, what is a histone? Histone is quite simple to understand, but before we show you what a histone picture looks like, the whole idea of these amino acid shifts kind of determining whether it is going to be K27 or G34 is a single shift of one amino acid. So it's quite interesting how the manifestation of these tumors differs so significantly. And gene names have been altered significantly based on these particular changes. Now, remember that though this is the primary matrix change, there is a significant overlap of diffuse midline gliomas with TP53ATRX, and we know these are all cancer predisposition genes which are happening in the background. Now, this is what histones are. Histones basically are proteins that are involved with packing the chromatin. If you remember the nucleus and the nucleolus and the dense genetic material information that the DNA contains, they have to be packed into tight compartments, and histones are actually responsible in terms of those purple things that are falling around these genes basically are packing it closely together. And if there's a mutation in the histone itself, which is organizing the DNA material, you will encounter problems with the genetics itself. So you can see how closely the genetic and the epigenetic phenomena function in many of these cases. Just wanted to show you what histones look like because we keep using these terms without understanding what exactly their function is. Now, we said WHO4 irrespective of histology. So even if your histology comes back as astrocytoma, and it could be a low grade, etc., the moment you pick up this mutation, that's a very important slide, it becomes a WHO grade 4. And in fact, in this particular cluster from China, I think, of the 61 cases they looked at, P53 was positive in a substantive 40 out of them. You can see why these are high grade lesions. That's a diffuse midline glioma, which was sent to us as a diagnosis initially of ADEM, which is acute disseminated encephalomyelitis. And if you give a diagnosis of ADEM, you start treating them differently. Bithalamic lesions, until proven otherwise, are high-end, high-grade diffuse midline gliomas. Once again, not very low on the ADC, not enhancing. This is a biopsy site that you see there. Spectroscopy not helping us too much. So I don't do much of all these so-called advanced technologies sequences. If something has remained advanced and esoteric for 40 years, I don't think it will really make it to common practice. I still rely on our basic sequences and try to use that. This was an NF1 positive. You don't expect to see a high-grade tumor in this case. So this 8-year-old girl with a unilateral diffuse midline glioma, again centered on the thalamus. And I find the thalamus quite fascinating because the surgeons will find it very tricky to get this entire tumor out. It's quite an invasive surgery, and you have to make sure that the corticospinal tracts are preserved. So they really need to know where the tumor is centered before we can ask them to go in and whether it's going to be a biopsy or a debulk or complete resection is planned. Companion case here of a 16-year-old boy with a more diffuse entity. Apart from being centered in the thalamus, it is spreading all the way through, and we have to tell our surgeons that complete resection here is not going to be possible. You can't really take the whole hemisphere out. So a bit more of a sad story out here, for instance. Now, those two entities were K27M mutants. Now, if you look at this, this is more diffuse, ill-defined, patchy bilateral. And this was sent to us with a diagnosis of MOG, which is myelin oligodendrocyte glycoprotein, a neuroinflammatory demyelinating condition. And actually, if you look at the picture, it does look like it. The confluent, ill-defined cortical, subcortical changes, bilateral. And if you look at subsequent scans, it also follows a bit of a relapsing remitting pattern, so to say. But this child did not respond to any of those frontline treatments for neuroinflammation, finally had a biopsy, and it came back as IDH wild type, and the mutation was G34, which you might remember from previous slides as a slightly different angle. And these have been referred to as diffuse hemispheric gliomas, again, quite high grade. And this child did not do too well in that particular case. Now, this was an older case, but the term glioblastoma was used in the pathology report. I don't think we'll see that anymore. Now, they can be a little more circumscribed. This is more in the infantile realm. This was a very young child with a large tumor. Now, in infants, they look quite aggressive, but the overall outcomes are not too bad because they get surgically resected and they do survive. The 5-year survival is not too bad. This turned out to be an astroblastoma, however, with this particular mutational signature. And you can see how they look different. The idea of these 45 minutes today was to show the differences in the structure. I'm not going to go into the details of pathology, but for the pathologists in the audience to prove the point that this was indeed an astroblastoma and nothing else. And then we talked about the glioneuronal cohorts. The glioneuronal cohorts traditionally used to be, the DNETs and the gangliogliomas. And you can see that these entities have been mentioned here. But pathologists started looking at their signatures, BRAF, FGFR mutational status. And based on that, there was a reclustering into group 1 and 2. And when I saw this paper, which was published in 2018, I thought, let's look at the radiology of these tumors. So I picked up the same cohort. This was from our own hospital. And I said, let's look back into the radiology. These were the group 1 tumors, and they seem to look very different from group 2. Group 1 tumors, you have an ill-defined temporal lobe location, usually mesial temporal lobe, 50% of them enhanced. And when they enhanced, they had this out of focus, ill-defined cotton wool kind of enhancement, not really a strong feature. And then we looked at our group 2 tumors. They were all outside the mesial temporal region. They were mostly extratemporal. And if they were in the temporal lobe, they were not medial temporal. They had this flare rim sign in 100% of cases. Now, we would identify these as our DNETs or gangliogliomas, but you can see how the 1 and 2s look quite distinct from each other. So it was a bit of a circular argument from a radiology perspective that we are going to pick up either BRAF signatures, they look like this, the BRAF mutated tumors, or we'll pick up something else, and this is where the other tumor subtypes were. And we know our DNETs can actually have these tails, etc., going towards the ventricular margin, for instance. And again, half of them did not enhance, but when they did enhance, it was very well-defined enhancement, not the ill-defined enhancement of a mesial temporal lesion. So we were able to start looking at differentiation, and the accuracy reached quite high, but I think the argument could have been a bit circular. The other glioneuronal tumors were initially, there was a cluster of 7 of these we saw from various parts of the world, which were being treated for tuberculosis. So we had to put it together into a case series, which was published a few years ago. But if you just look at the texture of this tumor, various things, depending on where in the world this tumor originated. Some people thought it's neurocysticercosis, or some people in India would have treated these as tuberculosis. You can see why this ill-defined nodular in parts enhancement around the leptomeninges of the brain and the spinal cord would have been called that. But they all turned out to have particular signatures which were in the realm of diffuse leptomeningeal glioneuronal tumors. And when we start looking at their radiology, they do look quite distinct. And this is a diagnosis that you think about to get it right. Most of these children presented in a very indolent fashion with just headaches, not much happening. They're very low-grade tumors, but look at the dissemination even at baseline on these particular scans. Now, going back to imaging, the term reverse phenotyping is something I like. And many of these tumors, which were traditionally called something with the new technology, had to be revised. And when they were revised from pathologists, we start looking back at their imaging. Now, there are 3 different children here. They're all of similar age groups, basically around early tweens, 12 to 15-year-olds. And they were all called high-grade PNETs of the brain, a term that is not used since 2016. Well-defined, not much in the way of perilesional edema, enhancement, and then which was patchy, and then calcification, which was strong. That was case 1. And you can see low ADC values on the diffusion, but you will pick that up when the calcification is so strong. And they all 3 cases looked similar to each other in different locations of the brain. And the pathology of these comes back looking at particular cell types. And this was then labeled and relabeled as diffuse glioneuronal tumors with oligodendroglioma-like features. You can see why you have a mixture of things going on here, oligodendrogliomas, and the diffuse glioneuronal components coming in. Now, when we published this series, we realized that this was going to be a questionable new entity in the new classification. The way new tumors are born is that there should be at least 2 publications from 2 different centers talking about the same entity. And then they kind of make it to the provisional list of WHO, pending confirmation for real entity by the next classification. The embryonal tumors, the traditional ones were medulloblastomas, and this is how 2021 classified them. Not much change in medulloblastoma world out there, but histologically defined medulloblastomas by themselves, useful for centers that don't do proteomics and high-end molecular differentiation, still very useful to treat them. And then the other CNS embryonal tumors. And in that particular subset, there were some new entities, the cribriform neuroepithelial, the CNS neuroblastoma, which was FOXR2 activated, and CNS tumors with B-core internal tandem duplication. Big words. I'll show you some examples. So first of all, going back to the DFKZ classifier, you can see that the differentiation of these embryonal tumors, they started separating out quite far away. Though we call them embryonal tumors, it's a misnomer. They're not all embryonal in origin in a way, but the subtypes are all very distinct from each other. And on imaging as well, they look quite distinct. Now we know what the medulloblastomas look like by and large. So I'm going to focus my attention a little bit on certain other ones. And in fact, this CT scan was initially read as a normal CT scan. And you can see why it's very difficult to see that what you don't see, because you don't see a fourth ventricle here. Only when you do the MR, you start looking at how defined this mass is, how low on ADC those values are, and again, not enhancing. So everything I've shown to you today seems not to be enhancing. So don't use enhancement as a discriminator in children because it doesn't work. But look at the ADC, very low values. In fact, the ADC here at 400 or something, which was quite low, highly aggressive mass. Does it look like a medulloblastoma? It's in the posterior fossa going into the brainstem, but not typically looking like a medulloblastoma. It's not in the cerebellum. And this particular companion case in a different location, this is supratentorial, well-defined. And this was one of those cases from 2015, which was called a supratentorial PNET, which was then revised into this particular diagnosis. And the diagnosis was etanter initially, and then ETMR in 2016. Embryonal tumor with multi-layered rosettes. And the description is based on the histology and what it looks like under the slide. So they can be supratentorial or infratentorial. And in all the cases of the 34 that we saw in our cluster yet to be published, they were well-defined, solid. Not even though they are high grade, they're not causing anything in the way of perilesional edema. And in fact, these changes that you're seeing are long-standing. This child also had some kind of a prematurity and other related problems. But the tumor itself, in spite of its size and aggressiveness, was actually quite defined in one particular location. And it wasn't showing any perilesional edema and that kind of spread which you saw with the diffuse gliomas. Companion case of ET-MR would be an ATRT, which is atypical teratoid rhabdoid tumors. And I show these two particular cases because they are differentials of medulloblastomas given their location and their embryonal aggressive high-grade nature. And this is a lesion which is centered in the cerebellopontine region. They have cysts. They can have a lot of hemorrhage. ATRTs are rather hemorrhagic and friable tumors. And the age group is important. They happen quite early on. ATRTs themselves are being separated based on their genetic signatures, but I won't go into the detail of that because the moment you pick up an ATRT, the idea is to go in there and resect it to completion, and the outcomes are best from there on. Whilst we talk about ATRTs and ETMRs as the two entities that you need to know from the perspective of embryonal tumors. These are the emergent subtypes, the FOXR2 neuroblastomas. Now, traditionally, we thought of neuroblastomas as entities that go to the skull, but here, these are entities that go into the brain parenchyma, and they were called differently, anaplastic astrocytomas and various other things. They can have a hemorrhagic propensity. They can present with metastasis at presentation. They look like high-grade gliomas. But when you get the pathology back, and this is still work in progress, are these distinct on imaging? Only recently we were able to put 25 cases from across the world, so to say. We asked many centers to give in their FOXR2 cases. And hand on heart, even though we are publishing the paper, I don't think you can see it at baseline and say this is a FOXR2 CNS neuroblastoma. But this is more for awareness because this is not an astrocytic tumor at all. This is an embryonal tumor. And its companion out there is this rare entity, high-grade neuroepithelial tumor, which has got the B core. Again, these B cores, etc., are to do with tumor suppressor oncogenes. Looks quite different, but it's in the posterior fossa. And in fact, we have just one or two cases of this. Now, B core mutation, you'll see a lot more in the head and neck cancers as well. So it is a space to watch. And my pathologists tell me that by the time the new classification comes out again in a few years, this entity might go away from embryonal tumors somewhere else. So we don't know much about this particular entity, apart from the fact that the one case I had looked pretty much like nothing else that I had seen before. Ependymomas, we did say that ependymomas still are being classified based on their location, but even on those location basis, there are subtypes that are emerging. In the infratentorial subtypes, things are a bit more clear-cut, and I will show you some example. You can't really distinguish between those two subtypes in the supratentorial area. The nomenclature that changed is we were talking about RALA fusions that has been replaced by ZFTA, and essentially these are the same pathway, and this is one step before the RALA. So this is an example of an ependymoma in the posterior fossa where you have a type A and a type B. Now look at the location. This is eccentric. It's in the lateral recess. Type B is midline, and that it seems to follow that rule. So you can be very confident. First of all, if you think this is an ependymoma, they are heterogeneous tumors. They are not all that uniformly low on ADC like medulloblastomas or ATRTs are, but they can be in the posterior fossa. They are less common compared to astrocytomas and medulloblastomas in the posterior fossa. If you pick up an ependymoma and you see that this is lateral recess, you call it a type A, happens in infants and younger children compared to older children and adolescents. So it's quite distinct from each other. And the type A and type B are to do with their biological behaviors and the fact that one has a stable genome with a poor prognosis, the other one has a chromosomal instability with a good prognosis. Because when the chromosomal makeup itself is so unstable, they do very well with complete resection and then adjuvant therapy to follow. On the other hand, we have supratentorial ependymomas, and these kind of look like each other. But to call that an ependymoma is more important because preoperatively, if I can tell my surgeons, and I think this is an ependymoma, you've got large cystic arrangements with solid components in there, solid cystic, heterogeneous, large lesions creeping onto the ventricular surface. Keep that picture in your head. When you see that, call that an ependymoma. The one tumor type where complete surgical resection means a lot in terms of the outcomes. And of course, they can come back, they can relapse later on in life. You can have late relapses as well. But if you got that post-operative scan clean, they will survive longer. And I did tell you about these ZFTAs and RALAs without really understanding much myself, but these are genes on the same pathway, and the ZFTA precedes RALA on that pathway, so it's better to call them. This is the kind of the diagnosis you will get: ZFTA positive ependymomas. And here another example of solid cystic, and the solid component can look quite aggressive, not to be construed as a high-grade glioma at that particular point in time. Finally, before we can have a little bit of consultation about these cases, is the whole idea of biology at relapse. Now, I showed you a case of an ETMR, which was in that location. This is the same case. So the ETMR was actually resected, and the patient was given given adjuvant therapy, chemo, radiotherapy, and then they were put on a surveillance. And when we look at surveillance scans, and this is an important message, particularly for children, you will see therapy-related changes, and these scans were read as therapy-related changes in terms of white matter changes that were progressing, and that particular case already had some kind of periventricular leukomalacia. It was only after a year and a half of surveillance that a radiologist thought that it's progressive therapy changes much beyond the completion of therapy, and that's a warning sign. Look closer, you can see that there is actually mass effect. These sulcal spaces are quite widened. Now, you're going to see a lot more of this happening because children will survive with or without good quality of life for a longer time once they are diagnosed and treated early. And this entity is in itself got a different genetic makeup. And there are just one or two case reports at the moment on the idea of radiation-induced gliomas, but it's not clear-cut just radiation-induced glioma. The radiation induces a change in the mutational setup of this tumor. And when you look at the literature of this, they have their own signatures. So it's kind of an emerging new entity, and we will see a lot more of this because the survival has been improved in terms of many of these tumor types. So the effects of therapy will show downstream. So what we are giving to these children might not be the best in terms of the poison chalice, so to say, in terms of treatment options. Summary, therefore, I'm very happy for you to have this. I'm not going to read out the slide, but this is a good thing to kind of put in front of you in your frame of reference, just to look at how things are called, the new entities, and then the revised terminologies. So from 2016, which was the last iteration, to 2021, the revised terminologies. And just to have an idea of what these terms are, rather than trying to separate them out on your radiology report. That's not the aim of this game. Finally, I'm going to leave you on the slide here. What is our role? And, this is a rapidly expanding scheme of things. I think from an imaging perspective, the way I see it, we have to go back and look at those cases. And when you have a new or a revised diagnosis, did the radiology actually look different? And there is a scope for characterization of new entities. Now, I'm a radiologist, so I'm going to be biased, but I think it's very important, not just for radiology, but even for surgeons, oncologists, and pathologists to be aware of what was done to the child, what was the initial tumor type, and whether the relapse looks the same as the original tumor or different. And that's a good place to start. And of course, on treatment, the biology and the behavior of the tumor itself can change. Now, we know that it's not one mutation in that matrix, so radiogenetics, etc., is lagging behind. But on treatment, how does the tumor change? And this kind of leads us into the realms of radiomics and trying to look at texture of tumors beyond what the imaging sequences show. And I'm going to stop there and provoke a discussion, give the screen back to Ronnie at this particular point in time, and stop sharing. And thank you for your attention.